Thank you, Dr. Kors, for that kind introduction. This morning, I'm going to discuss weight loss diets, weighing the evidence. If I can get the first slide up. Okay.
Yes, ma'am.
There we go. This is a topic that I think many of you are interested, but certainly your patients are very interested in. It's not advancing. That's okay, I can advance from here. It's okay. All right. I have no disclosures relative to this presentation. The objectives are listed here. There are just two simple objectives. I'm going to evaluate the evidence supporting or refuting popular weight loss diets and evaluate the effects of weight loss diets on energy expenditure, body weight, body composition, and metabolic parameters. Now, when we think about obesity, it isn't just a matter of fitting into that swimsuit after a long winter. But what we're really concerned about are these numerous comorbid factors that are directly related to obesity. And these are the factors that are going to impact global health. When we think about the treatments for obesity, there are several approaches that can be taken. Certainly lifestyle modification, which includes diet, physical activity, behavioral modification, pharmacology, and also surgery. Each of these is extremely important, and each of these has a particular role in the care of our patients. My comments today, however, are going to focus on diet and strictly diet alone. When we look at the indications for the various treatments, one of the things you will notice is that diet is really important along the entire spectrum of patients with various BMIs. And even those patients who undergo surgery, they will still need some dietary intervention and some guidance in terms of how they eat. So I really consider diet to be the foundation of weight loss therapies. Now let's face it, sometimes even Superman has difficulty maintaining his muscular physique and probably has attempted to try one or more of these diets. If you were to Google weight loss diets, you will see that there's well over 1,000 published diets on how to lose weight. And I've listed some of them here, but this is actually just a partial listing. Now, I'm certainly not going to go through the grapefruit diet, the chocolate lovers diet, or the latest movie stars diet. But there are some diets that have been studied in a randomized, controlled fashion that actually have some scientific evidence to back them up. Well, if you believe in the law of thermodynamics, and I do, when you take in more energy than you expend, you will gain weight. If you take in the same amount of energy that you expend, you maintain. And then if you take in less than you expend, you will lose weight. But I suggest to you, is the equation really that simple? When we think about obesity and factors that influence weight loss, there are numerous factors, and they are interrelated and dynamic, so they're always changing. So for example, if somebody is very physically active, that will change insulin sensitivity or insulin resistance. It will also, the diet, if you change that, will change the gut microbiota. The diet composition will change various things. How people eat is directly related to religious and cultural practices. Even things like the food supply has changed dramatically over the years. Our food supply is far more refined than it used to be. So I think it's more than just energy in, energy out. It's actually a very complex situation, and that makes managing these patients extremely complex. So my first question for the audience, and by the way, you do have these slides in the handout, but I did not put the answers in the handout. So the type and quality of carbohydrate or fat is not important. 200 calories from chocolate is the same as 200 calories from broccoli. Is this true or false? Very good. It is. It is false. So let's go back to looking at these equations now. Does it matter if the patient consumes carbohydrate at 4 calories per gram, protein, which also has 4 calories per gram, dietary fat at 9, or alcohol at 7? Well, first of all, what does 200 calories actually look like? It's a handful of jelly beans. It's a really big plate of celery, a lot of apples, maybe half of a cheeseburger. The difference is in the fiber content, the bulk of the food, and the water content, and this has an effect on satiety value. Barbara Rawls, who is a PhD RD at Penn State, developed this book, or designed this study, and came out with a book, The Volumetrics Diet Plan. If you look at this, both these meals have the same caloric content, but the diet down on the bottom has a much higher fiber content, higher water content. So she took students and during the weekend put them in a very controlled environment, like a CRC environment, gave them all the food they wanted but allowed them to eat ad lib. And then she varied the portion size and the energy density. So here you have 100% portion, 100% energy density. She then reduced the portion size to 75% but kept energy density the same. And there was a reduction, spontaneous reduction of 250 calories. When she reduced the energy density but kept the portion size the same, the caloric deficit was 550. And then when she altered the portion size and the energy density, the total caloric deficit was 800 calories. There was no significant difference in ratings of hunger or fullness, but the reductions in energy size independently, energy and portion size independently influenced the energy intake. Now, what's interesting is many of the food manufacturers have capitalized on this. And so this is an advertisement from Green Giant, and their emphasis is that more is better. So they're suggesting you can eat this big bowl of their vegetables or a handful of potato chips. Next question for the audience. Which weight loss diet or diets have been shown to beneficially impact resting energy expenditure and total energy expenditure? Is it the low carbohydrate diet, the low fat diet, or the low glycemic low diet, or perhaps low carb and low glycemic? Any guesses? Yeah. Wow, you guys are good. It is both the low carbohydrate and the low glycemic low diet. So the question to be evaluated: does altering the macronutrient content of the diet affect energy expenditure and therefore weight loss? There have been a few studies that have looked at this. This was a randomized parallel design study of overweight or obese adults, and they received an energy restricted diet, either a low glycemic low diet or a low fat diet. And they allowed the patients to lose 10% of their body weight. So here you have the low fat diet, low glycemic low diet. And then they measured the resting energy expenditure of these patients. And here you have the low fat diet and the low glycemic low diet. The resting energy expenditure decreased less with the low glycemic low diet versus the low fat. And that's a good thing, because you want the energy expenditure to remain relatively high, or as high as possible, as you're reducing body weight. Those patients also reported less hunger when they were receiving the low glycemic low diet compared to the low fat diet. And when they looked at the insulin resistance, triglycerides, C-reactive protein, blood pressure, there was an improvement in those factors as well. Now, Emily and colleagues attempted a similar study. This was a little different in design. It was a controlled three-way crossover trial. There was a run-in phase where the calories were restricted. Here's the run-in phase, so that they could restrict the calories and produce a 10 to 15% weight loss. Then, in random order, the patients were assigned to either a low-fat glycemic load diet, 60% carb, low glycemic index, 40% carb, or a very low carbohydrate, which was 10% carbohydrate. They then measured the resting energy expenditure and the total energy expenditure. So here you have resting energy expenditure, total, low fat, low glycemic index, and very low carbohydrate. The decrease in the resting energy expenditure and the total energy expenditure was the highest in the low-fat group, which is not what you want. You want to have the resting energy expenditure and total energy expenditure to be relatively high. So isocaloric does not necessarily mean it's isometabolic. Next question for the audience. Low-fat diets are as effective as low-carbohydrate diets in inducing weight loss and improving metabolic parameters. It is the total caloric intake that matters. True or false? You guys are really good. Yes, that is false. So the question I asked, what are the effects of macronutrient modifications on actual weight loss, body composition, and metabolic parameters? And I divided the studies into metabolic syndrome and those which were conducted in type 2 diabetes. These are the two big health issues that we're most concerned about. First of all, metabolic syndrome. This collection of factors, central adiposity, hypertension, dyslipidemia, insulin resistance, this constellation of factors that we now call metabolic syndrome. When we think about weight loss diets that have been designed to treat these patients, it's really this spectrum of carbohydrate and fat. On one end, you have the low carbohydrate, high fat diet. This is the most popular one, the Atkins diet. The original Atkins diet that came out many years ago was very high in saturated fats. It was high protein, but also very high saturated fat. They have modified this over the years, and now the diet emphasizes more healthy fats. As you go further down, the fat content is reduced and the carbohydrate content is increased. And some of these, like the Mediterranean diet, Barbara Roll's volumetrics diet, kind of in the middle, the Learn diet, which is more of a healthy diet lifestyle. And then when you get finally on this end, these are the really low-fat, high-carbohydrate diets. Neil Bernard's program and Caldwell Esteson's program. I worked with Dr. Esselson in my early tenure at the Cleveland Clinic, and I can tell you this diet is extremely low in fat. The patients are pretty much a strict vegan, and he does not even allow oils from plant sources, like no olive oil, canola oil. So it is extremely difficult to follow. The patients who were able to comply with this regimen did quite well, and we were able to reverse their coronary artery disease. So it works, but it's not so easy to implement. Okay, the Atkins diet, let's start with that. Is it friend or foe? If you look at this cartoon, the doctor is saying to the patient, you went on Atkins and lost 90 pounds, lowered your cholesterol, cured your high blood pressure, and now you're walking 5 miles a day. But I'm warning you, a low-carb diet is bad for your health. Well, I'm a registered licensed dietitian and nutritionist, and I have to admit, when I first heard about the Atkins diet, I thought, this can't be right. It's contrary to everything I've ever been taught. But if we base our practice on the scientific evidence, I think we need to look at this a little bit more carefully. How does this work? Well, the concept is you're trying to change the patient's metabolism. So if you burn carbohydrate, your respiratory quotient is at 1. When you ingest these carbs, you get an insulin secretion, and insulin is an anabolic hormone. And so these patients tend to create fat and store fat, and they gain weight. if you can reduce that, if you can change their metabolism so that they have less carbohydrate in, there's a reduction in insulin secretion, and you change their metabolism so now they're actually oxidizing fat with a respiratory quotient of 0.7, the patient then begins to actually mobilize their fat stores and use that as an energy substrate. Now, there are some mechanisms that have clearly been defined in terms of how this works, and others that we think are somewhat theoretical. When you put somebody on these high protein, low carbohydrate diets, there clearly is an appetite suppression. They just don't eat as much. So you don't eat as much, you don't take in as many calories, and then what happens is the body eventually utilizes their glycogen stores, and then they start mobilizing fat. There are some other theoretical mechanisms, perhaps inefficient protein and fat oxidation, because it's harder to oxidize protein as an energy substrate. It takes more energy to do that. And then lipolysis may be maintained despite excess calories because the glycerol from the fat is needed for this gluconeogenic precursor. And Atkins maintains that you can consume 5,000 calories on his diet and still lose weight, although I would not recommend that. As I started looking through the literature, there's actually a fairly robust, significant amount of literature that have compared low carbohydrate diets to low fat diets. And in each of these studies, and these were just the short-term studies from 1 to 4 months, but with each of them they showed significant improvement in their metabolic parameters as well as a significant reduction in weight. And even the long-term studies, 6 months to 2 years, the patients consistently lost more weight on the low-carb diet and had better improvement in their metabolic parameters. There was even a systematic review of these studies during the years of 2000 to 2007. There's an enormous amount of data in this paper, and I'm just showing you here the weight change at 6 months and weight change at 12 months, so 1 year out, patients who were on the low carbohydrate diet lost more weight. In addition to that, in this systematic review, they found that the low carb diet also resulted in improved cardiovascular parameters such as HDL cholesterol, triglycerides, and blood pressure. Now I'd like to look at just a couple of these studies in a little bit of detail here. This study appeared in New England Journal of Medicine. 322 employees at an Israeli research center, body mass index of 27 or greater. They were randomized to one of 3 diets. A low-fat diet, which was less than 30% fat. It was calorie restricted, and the emphasis was on grains, vegetables, fruits, legumes. Or they could have gotten the Mediterranean diet, which is a little bit higher in fat. It is still calorie restricted, more grains, fruits, vegetables, but they also included fruits, nuts, olive oil. And then finally, the low carbohydrate diet, which was less than 20 grams per day initially. That's the induction phase. And then they gradually increased the carbohydrate to 120 grams per day, but there was no calorie restriction. What you're looking at here on this graph is weight loss. And you can see that the patients in the low carbohydrate diet here in the purple bar lost the most weight, followed by the Mediterranean diet, and then the low-fat diet. They all lost weight, and they all gained some weight, but the greatest weight loss and the greatest maintenance of that weight loss was in the low-carbohydrate group. They also looked at the metabolic parameters, things that we worry about in metabolic syndrome. For example, HDL cholesterol, triglycerides, LDL cholesterol, and the ratio of total cholesterol to HDL cholesterol. And you can see with each of these parameters, the patients who were on the low carbohydrate diet did the best, followed then by the Mediterranean diet and the low fat diet. They all improved, however. Well, what about body composition and weight loss? This is one of the few studies that actually looked at changes in that weight loss, in the body composition. What does that look like? This was a study on women who had cardiovascular disease, and they were randomized to a low-fat diet or a very low carbohydrate diet, and their body composition was measured by DEXA. And this was done at 3 and 6 months. Now notice all of the patients lost weight, but the patients who were on the very low carbohydrate diet lost more weight, and when they measured the body composition, they actually lost more fat. And this is an important point, and I'm going to come back to that a little bit later. So it appears that when you restrict the carbohydrate, these patients not only lose weight, but they lose body fat. The other interesting thing that came out of this study is that when they looked at the patients who actually completed the study, it was higher in those who were on the low carbohydrate diet. So they were able to sustain that diet and be compliant with it for a longer period of time. Now, if you are in cardiology, one of the things you worry about are the effects of these diets on lipid levels, triglycerides, and things like that. And the mean values for blood pressure, lipids, fasting glucose, insulin were within normal ranges in both groups. So it didn't seem to impact their cardiovascular risk status. Now, Chris Gardner wanted to look at the effects of 4 popular weight loss diets. And he wanted to take more of a public health approach. Like your patients who go to the bookstore and they just buy a diet book. And so how does that impact their weight loss? So he designed this study, and they referred to it as the A to Z study. A being Atkins, T was traditional, that's really the Learn diet, Ornish, and then the Zone diet. And as you can see, they vary in terms of carbohydrate content, Atkins being the lowest carbohydrate content, and the Ornish diet being actually at least 70% carbohydrate. So the results of the study. First of all, although they were trying to create a public health type of situation, they did provide the patients with a little bit of help. So the patients did get the assistance of a dietitian, and the dietitian went over the diet, their respective diet with them. So she went over the book with them for 2 months, and then they had classes to make sure that the patient actually understood the concept of the diet. They provided incentives for the patients to remain on the diet. They had email, telephone reminders. So here you're looking at weight loss. Patients on the Atkins diet had the greatest amount of weight. Notice everybody lost some weight, but they all gained some weight, but Atkins lost the most. The other interesting thing is, once again, retention was higher in the group of patients who were on the Atkins diet plan. And then Gardner and colleagues also looked at the metabolic parameters. Again, this is one of the things that you tend to worry about when you're putting somebody on a high protein, high fat diet. All of the patients had an improvement in their metabolic parameters, but the group that was on the Atkins diet actually had the best change, or the greatest change, in their metabolic parameters. The question remains, is this improvement due to the composition of the diet, changing the macronutrient content, or is it the fact that the patient simply lost more weight? It's impossible to answer that question from this study because the study really wasn't designed to answer that question. Nonetheless, the patients lost more weight and had a better improvement in their metabolic parameters when they were on this low carbohydrate diet. So what about insulin sensitivity and insulin resistance? How does this play into the equation? This was a small study, but I think a very interesting study. These were obese, non-diabetic women, and they were on this 4-month feeding study. It was a hypocaloric diet, and they provided the food to the patients. So this is an important point. They were then placed on a low carbohydrate, low fat diet, a 60-20 profile, or low carb, high fat, 40-40. Now here you see the insulin sensitive ladies. When they were on the high carbohydrate, low fat diet, they actually lost more weight than when they were on the low carbohydrate, high fat diet. But if they were insulin resistant, the weight loss was greatest with the low carbohydrate, high fat diet compared to the high carb, low fat diet. And the differences were not explained by changes in their oral intake, their activity, or their resting metabolic rate. Very interesting. A similar study was conducted by Ebeling and colleagues. Slightly different design and slightly different way that they actually define insulin sensitivity and insulin resistance. These were obese young adults, 18 to 35 years, and they were randomized to this low glycemic load diet, 40% carb, or a low fat, 50% carb. It was a 6-month interventional trial with a 12-month follow-up period. The serum insulin concentrations were measured at 30 minutes following a 75-gram dose of oral glucose, and that's how they determined both the baseline and the measured insulin secretion. So the low glycemic load diet is in the dark bars here, or this is dark bars, and the low fat in the open bars, and this is all. And here you have insulin sensitive patients. You can see there doesn't seem to be a whole lot of difference. But when you look at the insulin resistant patients, the ones that were actually on the low glycemic load diet lost more weight than the patients that were on the low fat diet. So it appears that reducing glycemic load may actually be very important if you want to induce weight loss in patients that have a very high insulin secretion. So what about type 2 diabetes? Have there been any studies that have looked at altering the diet composition in this particular group of patients? Well, here's a small study, and these were obese patients with type 2 diabetes, 10 patients, so it's kind of small. They put the patients on their usual diet for 7 days, and then they followed with a low carbohydrate diet for 14 days. And what you see is they had a spontaneous reduction in their oral intake. But also, interestingly enough, here is the blood glucose level and the insulin level. There was a reduction in the glucose and the insulin levels. So these very low carbohydrate diets decrease the postprandial glycemic and insulin response. They also were able to demonstrate that the patients had a decreased plasma triglyceride and cholesterol level. So what if we were to randomize patients with type 2 diabetes? Does that matter? This was a study of 102 patients, type 2 diabetes, hemoglobin A1C between 8 and 12%, body mass index over 30. They were randomized to a standard diet instruction. This is something that most dietitians would do, reducing the fat intake, reducing the portion sizes. They got monthly group sessions. The other group was randomized to low carbohydrate, which was defined as less than 70 grams of carb per day. They also got the monthly group sessions. And here you see the results of their study. First of all the patients lost weight, but the patients in the low carbohydrate group lost more, and this was statistically significant. They all had an improvement in their cholesterol and HDL ratios, but once again, the low carb group had a more favorable outcome, and this was statistically significant. Although down here these were not statistically significant, the change in blood pressure and hemoglobin A1C again was more favorable in the group that had the lower amount of carbohydrate compared to low fat. Well, is it just a matter of low carbohydrate versus low fat, or does it matter if we actually alter the carbohydrate? And this was a very interesting study by Westman and colleagues, and they took overweight or obese volunteers with type 2 diabetes, and they were randomized to a low glycemic index diet or a low carbohydrate ketogenic diet. They all got group meetings, recommendations for exercise, nutritional supplements in terms of vitamins and minerals. The primary outcome in this study was hemoglobin A1C. And again, Both of these groups had an improvement in their hemoglobin A1C, but the group that was on the low carbohydrate ketogenic diet had the greatest improvement in hemoglobin A1C. So it isn't just reducing the carbohydrate. It appears to have the maximum effect. The patient really has to be in ketogenesis. Now, they also looked at the other metabolic parameters, things that we worry about. And again, when you're putting these patients who generally have dyslipidemia to begin with, you do worry when you put them on a high protein diet because it's going to be higher in fat. And once again, both groups improved in terms of metabolic outcome, but the low carbohydrate ketogenic group had the greatest improvement in these metabolic parameters. Well, a few caveats in terms of weight loss. Simply modifying the macronutrient content of the diet is really an oversimplification. So I can stand up here and say, well, you need to reduce the carbohydrate, increase the protein, lower the fat, but it isn't all that simple. The patient really needs to be instructed that the types of carbohydrates need to be high, complex carbohydrates that are high in fiber, they have a low glycemic index, have a very high water content, and they need to be instructed to eat less refined, simple sugars. The healthy fats need to be emphasized. So although the early Atkins diet encouraged people to have bacon and lots of cheese, and you can have a cheeseburger for breakfast but without the bun, they've now altered that, and really the emphasis is more on some healthy fats. And these are mono and polyunsaturated fats, as well as omega-3 fatty acids, and less of the unhealthy fats. These are the saturated fats and trans fats. And as far as the protein source, they need to be high biological value protein, and that includes marine sources of omega-3 fatty acids, plants with fiber, lean animal proteins, which are low in saturated fats. So which diet do you choose? Okay, is it diet A, diet B? Do you go with simply low carb, or do you go with the latest movie star diet? I think the decision is actually almost as complex as the diets are. The first thing to consider is what is the degree of obesity of the patient and their comorbid factors. What is their metabolic status? Are they insulin resistant, or are they insulin sensitive? Because that may influence the diet that you choose. Are there other medications that they are taking which may alter their appetite? What is their food intake like? What is their physical activity like? And what's the type of dietary approach that the patient might actually adhere to? And these are the types of things that you can get out of a good history when you're actually interviewing the patient. How ready are they to change? I've had patients come in and make it very clear to me that they are not going to do this, and they're only here because their doctor made them come. So somebody like that, you're going to fail. So the patient has to buy into this and be ready to make a change in their life. And then what is the degree of their literacy? And this is another important point. Some of our patients can't read, they can't add. And then if you put them on something like an Atkins diet where you're asking them to keep their diet between 20 and 25 grams of net carbohydrate, you're not only asking them to calculate out grams of carbohydrate, but the net carbohydrate, which is carbohydrate minus the carbohydrate in the fiber. So they have to be able to do the math. They have to be able to understand the concept. And there are some patients that are just not going to be able to do this. There are some patients who will not be able to follow a diet, and the best you will be able to achieve is to say, okay, eat half of what you normally do, and try and make your biggest meal early in the day. Is it optimal? No. Will it induce weight loss? Sure. So I think you have to look at this very carefully. We're working in the trenches in real life versus a controlled randomized trial. So I have a brief case that I wanted to show you to try and illustrate one of the patients that we saw in our nutrition and metabolic clinic. This was a 49-year-old female, and she came into the clinic. Her doctor had referred her for weight management. Past medical history was positive for hypertension, diabetes, asthma, sarcoidosis, morbid obesity. She was 5'4", weighed 115 kilos, body mass index of 43.4. Her hemoglobin A1C was 7.2, and you can see her lipid profile here: cholesterol 146, HDL 44, triglycerides 256. I took a diet history on her, and this is typical. They say, I've tried every diet out there. And most of the time that's true. They've tried the cabbage diet. They've tried the chocolate lovers diet. They've tried the movie star diet, and nothing seems to work. And a careful history revealed she was taking somewhere between 1,200 and 1,500 calories a day, which is not a lot for somebody who is 115 kilos. She had some simple carbs in there. She was taking Lantus in the morning and evening, and covers with additional blood sugar throughout, or covers with insulin for her blood sugars throughout the day. She would get short of breath upon exertion and even activities of daily living. So just walking down the hall, coming into the exam room, was very difficult for her. So I decided to try a low carbohydrate diet, high protein, and she was supposed to restrict the carbohydrate to 20 to 25 grams of net carbohydrate each day during the induction phase, because I was trying to get her into a ketogenic state. I asked her to begin walking, and I give them a walking handout, program. And it's very simple. We start out with 5 minutes a day, and then gradually 10 minutes a day. Because some of these patients, that, like I said, they can barely walk down the hall to the exam room, so they're not going to run a marathon. But if I can get them to walk, I think it's best for their overall health and general health. She was supposed to return to clinic in 2 to 3 weeks. Now, in the interest of time, I'm just showing you her initial visit and 3 months later. Notice the change in body weight over 3 months was not significant. She lost 11 pounds, and you might expect more, and you might hope that she would lose more. Her body mass index declined, but here's the important part. Her hemoglobin A1C went from 7.2 to 6.4. Lipid profile remained relatively stable, slight improvement, and she was able to reduce her insulin dosage. And then she said to me, I don't understand. I'm not losing a lot of weight, but all of a sudden I'm wearing a dress that I haven't worn in years. Think back to that study on body composition. She was losing fat, maintaining muscle, possibly even increasing muscle because she had started to walk. So that's a good thing. So when you're doing this type of diet intervention, the patient may actually lose body fat without necessarily losing a lot of body weight. But she had an improvement in these metabolic parameters. Now, the takeaway message, the summary today. A calorie is not always a calorie. And calories from foods that are less satiating can impact overconsumption. Macronutrient distribution can impact satiety. So those patients who are consuming a high protein diet generally tend to feel full longer. When you think about energy balance, isocaloric is not necessarily isometabolic. They are not the same. A low glycemic index and a low carbohydrate diet can beneficially impact the resting energy expenditure and the total energy expenditure. And here, individuals who are insulin resistant may have better weight loss and maintenance with a low carbohydrate diet compared to a low fat diet. But if you are insulin sensitive, you may do better with a high carbohydrate, low fat diet. I think it's also very important to monitor these high-risk patients. They need to be medically supervised and very carefully monitored. Ultimately, the best diet is the one the patient will follow and incorporate into their daily lives. And that's easier said than done. So I don't want people to walk away thinking that everybody should be on a high-protein, low-carbohydrate diet, because I don't think it's that simple. But there are some patients that clearly will benefit from that type of intervention, and other patients who will need the high-carbohydrate, low-fat diet. The other thing to consider is when you're modifying the diet, that the diet really needs to be sound and include all the nutrients, all the vitamins, trace elements, all the things that are necessary for life. So it just isn't a matter of altering the macronutrient content. I provided some additional references for those of you who wish to pursue this topic in greater detail. And on behalf of all my colleagues in the Division of Gastroenterology, Hepatology, and Nutrition, I thank you for your kind attention, and I would be happy to entertain any questions you may have. Questions? Yes, sir.
Thank you very much, Dr. Matarese. It was an excellent review of different diets. One of the questions that remains is patients' ability to calculate the carbohydrate and protein and fat content. As you mentioned, recently there were some suggestions about changing the food labels
Right.
and omitting certain information like calories from fat and so on. Your thoughts on that?
Yes, the USDA is considering changing the labels that we have on foods now. That's still up for debate, and a final decision has not been made. So they're taking comment now, so you can certainly weigh in on that. Obviously, when you think about weight loss here in the United States and globally, we haven't been real successful because I don't think people know what they're eating, or that's part of the problem. When even as a dietitian, when I look at that food label, I think it's complex and it's not clear what exactly you're eating. So I think the label does need to be changed. The exact way we change that, I think, is still up for debate. But patients need to know the calories that they're consuming, how much fat, and also the carbohydrate, and in particular, the type of carbohydrate. Like, right now, you can't tell, is that carbohydrate from fiber or is it sugar? If you're a registered dietitian and you know the composition of foods and you know how to read the label, yes, you could figure that out. But for the average individual, the average patient, it's impossible. But your point is well taken, and I think that the government is trying to do something in terms of helping individuals make smarter food choices. Yes?
So now with the changing healthcare reform, I think the focus is more towards preventative medicine, and obesity is obviously one of the biggest impacts on heart attacks and everything. So my question for you is, what is your vision as to how medicine should be practiced in, a busy primary care practice where you find new diagnosed diabetics, obese patients who walk in who don't have insurance?
I wish I had a really good answer for that, but I don't. And I give a lecture to the medical students, and this obesity is only a small piece of it. And I tell them, you know what, you're in the exam room and you have the opportunity to affect change in that patient. Problem is, you might only have 15 minutes. And you're trying to adjust their medications and everything else. Maybe they need an x-ray, blood test. So it is extremely difficult. I don't have a good answer other than for the patient that you know is not going to follow a diet, you can say, listen, cut your portions in half and try and eat your biggest meal during the early part of the day. That's a quick Band-Aid approach. Is it optimal? No. But that may be all you have during your 15-minute visit with that patient. If you can, for those really high-risk patients, it's probably worth referring that patient to a registered dietitian who can actually sit down with the patient and go through the diet with them and follow them and monitor them and help them through that process. There is no silver bullet. There's no easy way around this. And I think weight loss is extremely difficult. I mean, how many of us here in this room have tried to lose just 5 pounds and how difficult that is? So imagine if you have a body mass index of 60 or 70, and I've seen some of these patients in our clinic, they can't even walk. They're coming in wheelchairs or on stretchers. So it's just extremely difficult. Yes?
In my clinical experience, in patients who have tried the Atkins diet, what I generally see is that they do very well for a limited period of time, and then they crave carbohydrates, and it just sort of all falls apart. Is there any evidence that that is something that is likely to happen if you restrict carbohydrates too severely?
If they're following the diet, when they're in the induction phase, which is usually the first 2 weeks, where you're restricting the carbohydrate, generally 20 to 25 grams of net carbohydrate, you pull them into a ketotic state. And I'll tell them, if you're not measuring the ketones in their urine, I'll say, you will smell the ketones in your urine. It'll smell fruity and so forth. That's when they start to lose weight. The idea is you eventually slowly start increasing the carbohydrate by 5-gram increments until they're at their set point where they've lost the amount of weight they need to lose and they are maintaining their weight. If they go beyond that, that's when they start craving the carbohydrate. In fact, Atkins refers to it as carb creep. So I don't want to say they're non-compliant, but maybe they're adding too much carbohydrate back into the diet. They lose that satiating effect. The one thing I have noticed, though, and I don't have an answer for this, is that it works for a while, and then at some point, even if the patient has been compliant, they seem to stop losing weight. So I don't know if the body adapts to this or what. And I gave a similar talk in an international meeting, and a physician from Poland came up to me and asked me that same question. So there's something that happens that even though the patient isn't cheating and they actually are being compliant, counting their grams of carbohydrate, the body at some point must adapt and say, listen, I need more. So I don't know. I think there's a lot we don't understand. Probably for some patients, the best approach is maybe start them on an Atkins, get them to lose the weight, and then I would switch them over to more of a Mediterranean type diet, which I think is an overall healthy approach to weight loss and weight maintenance. Yes, Sharif.
Regarding this program that a patient is following in losing weight, most of the patients before reaching their low point, they reach that plateau phase. How do you deal with this?
The plateau phase, that is a difficult thing. First of all, you have to encourage them to stay with it. They're really happy and motivated in the beginning because they're losing weight and they're like, yeah, this is great. And then they plateau. If you can have them increase their exercise so that you do, change that equation a little bit so that they actually expend more than they take in, that may help. And then eventually they will start to lose more weight. But I think that's the only way. They have to increase their energy expenditure to overcome that plateau and encourage them to stick with it. Any other questions? Yes, Dr. Jones.
How I think would always ask, one of the things I find seeing patients, even in the diabetes clinic, is it's amazing. Even our diabetics, how many of them are still drinking sugar-sweetened beverages?
Oh, I know.
I mean, that seems like such a simple thing, but.
And here in the South, I'm a Yankee, so I moved here from the Northeast, and I'm adapting to this. And I had to learn that, when you go to a restaurant and order iced tea, you have to specify unsweetened because it will be sweetened. I think in my opinion, that's the easiest cut to make, sugar-containing beverages. And I really think sugar is the new fat. In other words, we used to focus on fat in the diet, but I really think the sugar is the bad guy. And I think it's a huge problem. I can tell you a story. When I was at the University of Pittsburgh and I was working with intestinal transplant recipients. And, you know, the interesting thing is that we had a cohort of patients who, after intestinal transplant, became obese. And all of a sudden, they had this new bowel, or gently used bowel, that actually worked, and they were gaining weight. And some of them to the point where they were morbidly obese. And I saw this young man who was approaching 300 pounds. And I took a diet history, and his diet was actually very good, very healthy, probably better than mine. But he was drinking 3 liters of Coke every day, regular Coke with the sugar in it. Took him off that. I said, you have to stop that, switch to diet if you have to, drink water, stop drinking the Coke, and sure enough, he lost the weight. Now, that was an easy, simple fix. They are rarely that easy. But, you know, I think it highlights the point, the number of calories that people consume with sugar-containing beverages. Anything else? Well, thank you very much for your kind attention. I appreciate it.